sit underneath the heart muscle to help with circulation. Well, that happened for the first time in 1950. Now, of course, everything was not great. We had a French physician who died on this date in 1814, Mr. Joseph or Dr. Joseph Ignace Guillotine. Promoted a law to use a machine that allowed to behead people. Now, finally, on this day in 1953 was the date when Jonas Salk announced a new vaccine to immunize people against polio. I am sure that he intended this vaccine for everyone and not just those who were able to afford it. And with that, I'll leave you with Dr. Barb Casper.
Good morning. I appreciate everybody's attendance this morning. I think this should be a really thought-provoking and interesting lecture. I'm very happy to introduce our speaker, Dr. Garrett Adams. Dr. Adams originally is from Nashville, Tennessee, and is a graduate of Vanderbilt University and Wake Forest School of Medicine, where he was recognized as a distinguished lecturer. He completed pediatric residency at Vanderbilt University Hospital and Children's Hospital in LA, and Pediatric Infectious Disease Fellowship at the University of Colorado. He has a master's in public health from Johns Hopkins University Bloomberg School of Public Health, by whom he was recently recognized with the Distinguished Alumnus Award. In 2014, he was the Granger Lecturer at the Yale Child Study Center and Yale University School of Medicine. He is retired from full-time faculty at the University of Louisville School of Medicine, where he was Chief of Infectious Diseases and Medical Director of Communicable Diseases at the Louisville Metro Health Center. During his 40-year career, he attended the health care needs of sick children and their young families, and he personally witnessed deterioration in healthcare access and healthcare delivery in the United States, and now works for a healthcare reform as a member of the Physicians for a National Health Program. He is a founding member of the PNHP Kentucky, a member of the National Board of PNHP, and was the national president of PNHP in 2010-2012. So he has quite a bit of experience and interest in this area. He is the founder and medical director of the Beersheba Springs Medical Clinic in Beersheba Springs, Tennessee, a not-for-profit volunteer clinic in the Cumberland Mountains of Tennessee. In 2011, he testified to the U.S. Senate on Is Poverty a Death Sentence, based on his experiences in Appalachia. At a time where there is a very robust discussion on how to address the healthcare needs of millions of Americans, I think his discussion this morning will be quite timely. The title of Dr. Adams' talk is Why Doctors Support a Single Payer, and I hope you will join me in welcoming Dr. Adams today. Dr. Adams.
Good morning. Thank you, Barb. I have great respect for the discipline of internal medicine, and for me it's a distinct honor to have Grand Rounds present Grand Rounds here. In August of 2003, when I was at the health department, I was leafing through JAMA and I saw an article, The Physician's Proposal for a National Health Plan. This is interesting. And I signed up and joined PNHP. I was telling one of my friends of my interest, and he said, you and what other doctor? So there were 8,000 of us at that time. Today, we're nearly 20,000. The physician's proposal is now, the principles of it are embodied in a resolution in the Congress from Congressman John Conyers, House Resolution 676. It was reintroduced in this 114th Congress as the expanded and improved Medicare-for-all Health Act. The message is that single payer replaces the health insurance industry and substitutes cost-efficient central planning for market-based healthcare profiteering. The term single payer means that one fund administered by a nonprofit government agency accountable to the public, would make payment for all medical services. Eliminating private health insurance from the system would save $400 billion, enough to provide all medically necessary care, mental health, hearing, vision, dental, all medically necessary care, even long-term care. Free choice of doctors and hospitals, again through a publicly funded but privately delivered health system. Physicians and other providers would be paid by fee-for-service or salary. All hospitals would convert to nonprofit and would be reimbursed annually on a global budget basis, allowing for central planning and cost savings. The program's expense would be paid by administrative savings and progressive taxation. Without premiums, co-pays, and deductibles, 95% of Americans would have more money at the end of the day than they have now. That's single payer. The title of my lecture implies that doctors support single payer. Do they? The answer is an emphatic yes, they do. Between 2007 and 2014, physician polls were performed in New Hampshire, Massachusetts, Maine, and Minnesota. The questions were similar. Do you favor a simplified payer system in which public funds collected through taxes are used to pay directly for services to meet the basic health care needs of all citizens? The results were also similar. 64 to 67% of all physicians supported single payer. In New Hampshire, 81% of primary care physicians said yes. In Massachusetts, of 5 options that were presented to the practicing physicians, far more preferred single payer than any other option. The American College of Physicians endorsed single payer as, quote, one pathway to universal coverage. In 2007, a survey of 2,193 physicians randomly selected from the AMA master file showed 59%, quote, support government legislation to establish national health insurance. 83% of psychiatrists, 71% of pediatric subspecialists, 64% of general internists, and 55% of general surgeons support national health insurance. The surgeons' increase to 55% roughly doubled this support that they showed in a similar survey 5 years earlier. There are now more doctors immigrating to Canada from the U.S. than the reverse. The number of American doctors coming to Canada has increased many-fold. Ever since 2004, there's been a net immigration of physicians from abroad to Canada, reversing a prior immigration trend of Canadian physicians. Dr. Sheriff Emil is one of those American physicians moving to Canada. Dr. Sheriff, a pediatric surgeon, left the University of California, Irvine School of Medicine to become chief of pediatric surgery at Montreal Children's Hospital. In 2010, he was asked to come back to UCal Irvine to deliver the commencement address. And I want to read you what he said. It was interesting for me as an American physician practicing in Canada to see the recent negative depictions of the Canadian system in TV ads and lay media, depictions that bore absolutely no resemblance to the actual environment in which I practice daily. My reality is very different. I can see any patient, and any patient can see me. Total freedom of practice. My patients' parents have peace of mind regarding their children's health. If they change jobs or lose their job altogether in a bad economy, their children will still get the same care and see the same physicians. Micromanagement of daily practice has become a thing of the past for me. There are no contracts, authorizations, denials, appeals, reviews, forms to complete, IPAs, HMOs, PPOs. Our division's billing overhead is 1%. My relationship with the hospital administration is defined by professional, not financial standards. I have no allegiance to any corporate or government entity, nor does one ever get in between me and the patient. This environment, which some denigrate as the ever so scary system of, ever so scary system of, quote, socialized medicine, allows for more patient autonomy and choice than was available to most of my patients in California, end quote. Single payer is good for doctors because there's a freedom to make decisions. There are fewer administrators and more providers. There's an end to uncompensated medical care, improved reimbursement, an end to undercompensation for Medicare and Medicaid patients, expanding practices, improved continuity of care. Patients no longer will be forced to change to different providers or hospitals when they switch jobs or their employers switch providers. Malpractice costs will fall dramatically. Number one, about half of malpractice awards go to pay present and future medical costs. Single-payer national health insurance will eliminate the need for these awards. Single-payer facilitates long-term continuous caregiver relationships, improving communication between doctor and patient. With single-payer, no money changes hands between the provider and the patient, removing a frequent source of conflict between the provider and the patient. Malpractice costs in single-payer countries, Canada, Sweden, and Denmark, have been studied. All have much lower costs than the United States. Malpractice costs in the United States will fall dramatically with single payer. House Resolution 676 will address the nursing and primary care crisis. A budget will be established to assure that adequate numbers of primary care physicians and nurses are trained and available to maintain quality. On the basis of the Canadian experience, under national health insurance, average physician incomes would change little. And I'll give you a few of those from a survey from the Canadian Institute for Health Information for 2012-2013. The average income for all Canadian physicians was $317,649, ranged from a low of $268,000 for family practice to a high of $580,000 for ophthalmology. Internal medicine was $370,000. When financial barriers to care are removed under a single-payer system, the increased number of patient visits will be offset by improved resources from the reduction of administrative overhead and physicians' paperwork. Billing, for example, will involve simply imprinting the patient's national health program card on a charge slip or sending it electronically. And you contrast that with the current average U.S. physician billing cost, which is 13% of revenue. American billing costs amount to almost $83,000 per physician per year. And office staff time spent with payers is just over 20 hours per physician per week, nearly 10 times that of Ontario. Finally, I would like to read from a recent address by Dr. David May, MD, PhD, Fellow American College of Cardiology, and a recent chair of the Board of Governors of the American College of Cardiology. I am a Republican. For those, this is a quote, I am a Republican. For those who know me, that is not a surprise. I live in a red state. I have never voted for a Democratic presidential candidate. I can field strip, clean, and reassemble a Remington 12-gauge pump blindfolded. And on top of it, I think we should talk about having a single-payer national health system. I think that the physician should be in charge of health care and not the insurance companies and hospital systems. Maybe I should repeat that sentence. I think physicians should be in charge of health care and not the insurance companies and hospital systems. With the single price structure, it becomes all about medical decision-making, efficiency, the provision of care to our patients, and shared decision-making, all of which we do well. How, you might say, could a Republican come to such a position? The simple answer is, I really think it is quite Republican. Oh, I know there will be many raised eyebrows and many critics. I accept that. I understand the fact that no single-payer system is perfect, that it is, quote, socialist, that it is, quote, un-American. I would submit, however, that it is un-American to allow many of our citizens to be uninsured, that it is un-American to support a bloated, inefficient, and fraud-laden healthcare system, that is un-American not to be open and above board with the cost of what we make, with the cost of what we do, the expense of that service, and the profit that we make. Mostly, it is un-American to let this outrageous healthcare injustice continue. Dr. May provides the final reason that doctors and 2/3 of the American public support single payer. It is the right thing to do. Our market-based, multi-payer, private health insurance system has failed us. Our health outcomes are worse than peer nations. Yet we spend more than twice the average of those nations, more than $8,000 per capita, and all of those nations provide universal care. In 2019, in spite of the Affordable Care Act, there will be at least 30 million uninsured, 30,000 deaths due to lack of health insurance. We soon will be spending 19% of our GDP on health care. The Affordable Care Act is unaffordable. Medical debt is still the major cause of personal bankruptcy in America. Insurance companies now embedded in our health system by the ACA will continue increasing profits at the expense of patients. As Kay Tillow says, they have more tricks than Wile E. Coyote. U.S. prescription drug spending continues to rise, as do the cost and the profits. The profit of the top 10 pharmaceutical companies in the Fortune 500 exceeds the total profit of the other 490 companies. Americans pay roughly 40% more for our medicine than the VA or other countries. In 2010, we opened a free clinic in Beersheba Springs, Tennessee. We purchase medicines wholesale and provide them free for our patients. There's a scandalous increase in recent drug costs. For example, our cost for bulk doxycycline from September to October went from $70 to $700 in 1 month. Glimepiride, an oral hypoglycemic agent, went from $13 to $318. Grim statistics, but statistics blunt the real pain and suffering. Statistics are people with the tears wiped away. We opened the Beersheba Clinic not because of the lack of available health care, but because of the lack of affordable health care. Beersheba is the poorest county in Tennessee and has the worst health outcomes. My friends and neighbors were suffering. I knew this intuitively, but since we opened the clinic and I've witnessed their pain firsthand, it has been a profound experience. A couple of years ago, I described this sad reality in testimony for Senator Bernie Sanders at a U.S. Senate hearing entitled, "Is Poverty a Death Sentence?" I spoke about people I have known, all of whom failed or were failing to get the life-saving health care because they couldn't afford it, for whom poverty is, has been, or will be a death sentence, and also to those for whom illness is a poverty sentence. I encourage you to view the full testimony at worshipaclinic.org, and that along with other websites, the Physicians for a National Health Program website and the Kentuckians for Single Payer are on the reading list, which I've prepared. I hope you'll all get that. There are over 1,200 free clinics. Let's see, right now, I want to show a brief video. This is from The Daily Show with Jon Stewart. It's titled Third World Healthcare, Knoxville, Tennessee. I pushed it.
Welcome back. You know, we've all heard America has the best healthcare system in the world. But for how long? Asif Manvi has more.
The U.S. healthcare system for as long...
Find all your Easter surprises at Kmart.
Sorry,
Get
we're
great
playing it
extra
off the,
deals
we're
with
playing
girls'
off the
dresses for
website,
$12
so it's,
and kids' shoes for $12. Plus
so
Easter
unfortunately
baskets.
you're getting an ad for Kmart. Here we go.
Welcome back. You know, we've all heard America has the best healthcare system in the world. But for how long? Asif Manvi has more.
The U.S. healthcare system, for as long as we can remember, has had one resounding truth.
America has the best healthcare system in the world.
The greatest healthcare system in the world.
The finest healthcare system in the world.
But that's all about to change.
Obamacare will bankrupt our country and ruin the best healthcare delivery system in the world.
Fox Business commentator Todd Weilman.
The U.S. healthcare system is the best in the world, but now with Obamacare, you know, our choices have been limited. You know, people are going to be saying, this costs more, I'm getting less, I'm not going to be happy.
Worst case scenario, where are we heading?
We have longer lines. You might have to bring your own sheets. In Russia, they reuse syringes. The scenario where we could slip into third world status will be slow, probably.
Oh my God, third world status? That's like the worst world status there is. To see how bad that could be, I traveled to a region rife with poverty. My guide was Stan Brock, founder of Remote Area Medical. For 30 years, Brock and his charity have parachuted into remote regions in Africa and South America with teams of doctors working to heal the poor. And now he would show me what America will look like in just a few years. Stan, how high are we going to go up?
You don't need to scream at me. The rotor's not going yet. We're still on the ground.
Oh. Okay, yeah, I've never been in one. This is my first time. Anxious for the long journey ahead, we buzzed over an unfamiliar and rugged landscape. When I arrived, I was overwhelmed by the need.
Do you find that there's diseases and things, conditions here that you're not even familiar with? Dengue fever, typhoid, malaria, things like that?
No, those aren't problems that we really see in Knoxville.
I'm sorry, you said Knoxville?
We're in Tennessee.
With Tennessee?
Tennessee. Knoxville, Tennessee.
Knoxville.
Yes.
Knoxville. Oh, all right. And that's what the locals call this place?
Yes.
And what's the English word for it?
Knoxville.
This is Knoxville, Tennessee. This is America.
Oh, that explains it.
Oh my God, I think I saw a Waffle House.
But if we were in America, what the hell was Stan Brock doing here?
Remote Area Medical have been designed to take airborne relief, parachute drops, etc., to the third world. And now more than 90% of everything we do is here in the United States.
And is that because 90% of the world's population is American?
No. When I came to this country, I saw that there was a desperate need, people that couldn't afford or didn't have access to care.
The U.S. healthcare system is the best in the world. Fact.
If you can afford it.
Name 5 other countries that have a better healthcare system than the U.S.
Malta, Cyprus, France, Switzerland, Japan, Australia, Great Britain.
All right.
Yeah.
You named like 7.
Yeah.
And I said name 5, so you lose.
Okay, so maybe we're not the first best or second best, but at least we're in the top 37? Whatever. In your face, Slovenia.
So I just came back from a place with shockingly poor healthcare conditions. We're still reeling from the loss of a civil war. A quarter of the young people are living in poverty. They have high rates of cancer, heart disease.
This is how bad it could get, sure.
Yeah.
If we keep going down the path of more government control, less innovation. I don't know if we could be that place unless great catastrophe happens to this country.
I should probably mention that the place I'm talking about is Knoxville, Tennessee, in America, which has the greatest health care in the world.
What, obviously not, people do fall through the cracks.
And from what I saw, those are some pretty big f***ing cracks. So the worst case scenario for Obamacare is that it gets us to a place where we already are? So what happens now when you're sick?
You're still going to get the care. It's going to be not
good.
It's not so much not good. It's going to be
not what everyone else is getting.
Everybody else gets it. It's going to be they all get the same level of health care, but they're going to have to wait for it.
It's the same treatment. You just might get that treatment after you've already died.
No. Some people get great health care, and some people just get good health care.
But what if everybody got really great health care? I'm just kidding. We have to keep things competitive, right? Yes.
See, everyone gets care. It's just some have to wait for it to be choppered in with a triage unit. But that's their choice.
Not all of them cannot afford health care. They've made that choice to go bare.
Because they can't afford it.
Because they don't want to pay for it.
Well, because they can't afford it.
People like a free lunch. And I'll be honest, if you're poor, stop being poor. Get a GED, have a job for over a year.
Right. So if you're poor, just stop being poor.
That's a good idea.
It's a great idea. Just no one tells Slovenia.
Awesome, Monty. We'll be right back.
All right, thank you. That was Asif Mande on the Daily Show with Jon Stewart. There are over 1,200 free clinics in America. Remote Area Medical provides free care to tens of thousands of destitute, sick Americans a year, an indictment on America's dysfunctional health system. I wonder how many in our audience have participated in a free clinic. Oh, look at this. Look at that. Wow. As much as I love our free clinic in Bursaspor Springs, I know that what my patients need is not charity, but social justice. Social justice is a new phrase in my vocabulary. Others are racism, white supremacy, white privilege, elitism, wealth inequality, and politics. Racism has its roots in slavery. In a recent essay, Ta-Nehisi Coates says, "No statistic better illustrates the enduring legacy of our country's shameful history of treating black people as sub-citizens, sub-Americans, and subhumans than the wealth gap. The Reverend Martin Luther King Jr. said, "Of all forms of discrimination and inequalities, injustice in health is the most shocking and most inhuman." Former Surgeon General David Satcher and Dr. Adewale Troutman, former medical director of the Louisville Jefferson County Medical Health Department, and others wrote a paper entitled, "What If We Were Equal?" citing 83,000 excess African American deaths per year because of health inequalities. African American infant mortality rates in southern states are more than twice the white infant mortality, and African American maternal mortality is terrible. Of all developed nations, the United States has the most unequal distribution of income between rich and poor. The richest 400 Americans have more wealth than the entire bottom half of the population. So what? Our wealth inequality has grave consequences. As income inequality increases, the range of social problems and poor health outcomes increases. There's a one-to-one correlation. The U.S. has the largest wealth gap, and we also have the worst health and societal outcomes among developed nations. We have, among 23 developed nations, according to a book that I've cited in the reading list, The Spirit Level, Life, and by health economists, I should explain, in Great Britain. This is a very well-researched and wonderful book. Among these 23 nations, we have the largest wealth gap, we have the shortest life expectancy, the worst infant mortality, more teenage births, more obesity, more mental health problems and addiction, less math, literacy, and education, less social mobility, more homicide and violence, more imprisonment, and less trust and community life. A national publicly financed single-payer health plan would be the best thing that could ever happen to this country. In one fell swoop, on at least one level, health, everyone becomes the same. We not only improve the nation's health, but we seriously commit ourselves to a true democracy with liberty and justice for all, and we build a better society that more equality can bring. I've thought, what if we went into Ferguson, Missouri, and we said, okay, today everybody gets the same health care that everybody throughout the country gets, and it's going to be a high-quality, good health care. Would that make a difference? 59% of American doctors and 2/3 of the public support such a program. That's political feasibility. It's also economically feasible. According to Professor Gerald Friedman, chair of the economics department at the University of Massachusetts Amherst, who recently showed that under House Resolution 676 in 2014, by slashing private insurance industry administrative waste and reducing pharmaceutical prices to European levels, the U.S. could save an estimated $592 billion a year. The savings would be enough to cover all the uninsured and upgrade benefits for everyone else. So why don't we have it? Because of the powerful opposition of the medical industrial complex. In 2009, the healthcare lobby spent $1.9 million a day to get the system they wanted. But a strong people's movement can overcome this opposition. This is a movement for all the people. And it will not be stopped any more than the civil rights movement or women's suffrage could be stopped. I hope we have some recruits today. I've put some applications for membership to the Physicians for National Health in the blue application folder. Also, we will circulate or have outside some pads where you might write your name if you'd like to have, if we can contact you if you'd like more information. We also have handouts. The Kentuckians for Single Payer Health Care meet at 5:30 on the mezzanine floor of the downtown library on the first and third Thursdays. All this information is at our new website, newly revamped website, kyhealthcare.org. And that, again, is on the reading list, which I've supplied. And also the background for the wealth gap information and the bad social and health outcomes is there. The book is listed. So also at KY Healthcare, you'll see a list of showings of the healthcare movie. It was a great movie that just came out, and we're showing that at branch libraries throughout the city. So thank you very much. And now there's time for questions and comments.
Thank you for that presentation. So we do have quite a bit of time for discussion, so that's great. When you mentioned the salaries of Canadian internists, I thought the audience would just run to the border. But seriously, you described a beautiful setting of health equality and single-payer system. There are a lot of smart people in this country, and yet we can't make that happen. So where are the problems? And I'm going to start with the question that I'm always asked all the time is, how does a system like that address the issue of innovation? How do we continue to stimulate innovation in a single-payer system?
Well, I'm going to be like that Philemon, though. That guy, and he was caught and he didn't know what to say. But I'm thinking of my answer, and the first answer that I'd like to give is that there's been no problem with innovation in Canada, with France, in the United Kingdom. I was on an airplane not too long ago, and my seatmate was a young surgeon from the University of Louisville who was a fellow in surgery, and he was just returning, Jesse, from a conference in Paris where they were going over the latest techniques for endoscopic surgery. If you read, there are more medical articles published from abroad than there are here. We're fast falling behind. I think if you look at citations in your field, for example, you'll find that there's no lack of innovation. I remember reading about an orthopedic surgeon who was attracted to go back to Canada because they gave her a robotics laboratory. So that is one of the memes, if you will, misinformation, which is promulgated, this thing like America has the best health care. That little phrase came from a public relations firm, the same firm that worked with the tobacco industry. A similar kind of thing is where socialized medicine came out. When Harry Truman was wanting to set up universal health care, the AMA was scared, and they hired a couple to counteract it, a public relations couple, and they came up with socialized medicine, and they made it sound just like this guy did, where you'll have to bring your own sheets, that kind of thing. So I think innovation will not be a problem. Another point to make here is that we're spending more than twice what other countries. If we put all that money into health care and into the general system, then we're not going to have any problem with innovation.
Questions?
What fuels innovation now? Well, most of the research, as you know, is funded out of the National Institutes of Health, which is, I think, a wonderful example of how our government can do things right. The National Institutes of Health, the Centers for Disease Prevention, and I think the thing that fuels innovation is, Jonas Salk, as Dr. Roman pointed out, didn't develop the Salk vaccine for his own profit. He didn't, he gave that away. Let me tell you a quick story. One of my pediatrician friends, when the Salk vaccine came out, was in a small practice, and they were talking in a business meeting. There were 3 or 4 of them, and they were trying to decide whether or not they should adopt this new polio vaccine. And the man who was the head of the practice at that time said, "Hold on a minute." He picked up the phone and he dialed a number and he said, "Jonas, is that shit of yours any good?" That's a true story. I love that.
I brought up the issue of innovation because this is one of the questions that people bring up. Now, innovation is done by people. People want to make a difference. Physicians who are here never went into medicine because they wanted to make more money than anybody else. It becomes later a big issue when you start caught in this system where everything becomes monetized. No? So we have moved innovation from being driven because we want to do good, because we want to have money. So all of this is part of the same process. No? This is a cultural change. This is not about making a single payer system. This is about changing the entire cultural nature of this society. It is a big deal. It is a big deal. I saw another hand up. Yes, sir.
Could you speak up? I'm not quite getting what. Well, I mentioned the physician's proposal for a national health plan that I read in 2003. A new iteration of this proposal is in process of going through an editing and process, and will be out before too long, I believe. And that takes into account the accountable care organizations. One could say this, that the remuneration for physicians, for example, will stay the same, so as it was in the earlier proposal, and that is either fee for service or salary, and the salary could be from a not-for-profit institution, or could be from a capitated organization, which is such as an ACO. But the ACOs must be not-for-profit, as Dr. Roman has so clearly pointed out. There's this wonderful healthcare movie this young woman went to Canada and she interviewed 390 people, just people that she met. And there's one that I remember, and this woman said, we have to get the business and the profit taking out of medicine. And so if you do that, then you're free to take care of people and to innovate, and there's no problem. I didn't see a single problem with those salaries. As a matter of fact, that's probably 2 or 3 times more than I ever made here. Yes, sir. Yes. Well, you're comparing the VA to Canada, and I'm not sure if that's a logical if that's a fair comparison. There are a lot of things to recommend the VA, and I was not aware until you said that about the administrative burden there, which would be an important thing to think about and hopefully to change. But the VA, in some ways, has excellent health care. There was a book by a guy by the name of Long who wrote the book, and he said the best care anywhere is the VA. The VA has excellent records on taking care of heart disease, for example, hypertension. They're sticking with the guidelines, and so not that there are not problems, and this is not going to be perfect. There will be difficulties, but some people say, for example, you're just trading one bureaucracy for another one. Yeah, but the difference is that if I'd rather work for officials that I've had a role in selecting, such as Congressman John Yarmouth, for example, rather than working for a bureaucratic insurance executive.
I would also add, because I'm a VA doc, and there are many people who are VA docs, that the VA system spends half of what the rest of the United States spends in healthcare, and their healthcare outcomes, as you just heard, are equal or better in multiple areas. The problem is you will see great VAs and you will be seeing terrible VAs, which tells you it's not about the VA system, it's about the people that work in each of these places. It's the people who work in each of these places that make a big difference. Dr. Wendy.
So the dramatic costs, we all recognize pharmaceuticals, devices, procedures are dramatic for the benefit of pharmaceutical companies, physicians, hospitals. I don't understand how having a single payer really is going to address and reverse that. Isn't that a fundamental and perhaps less radical program that we could direct our interests and energies into solving all the dramatic increase in costs without dismantling the entire pharmaceutical and insurance industry?
Well, that's another. No. This is why I left the time, for these kinds of questions to discuss them. You can't do it without getting. It's like you can't. Jim Hightower said you can't get clean water until you get the pigs out of the creek. that's a kind of a crude way to say it, but the thing is that there's a difference in motive. I mean, the bottom line for example, the CEO salaries are just completely out of line. There was you mentioned medical devices. The CEO of Mckesson several years ago had a salary of $128 million. Was given $128 million. That's the highest, most egregious salary, and this is coming out of patient care. So we just need it. We have to get control of it. Why should we pay 40% more for our medicines than people to the north and south and across the Atlantic? Why should we? I don't know that I've fully answered your question, but. There would be.
Would it also drive, do you think this system would drive more kids that are now maybe going into business or something else to maybe consider medicine here in the United States? It would help all recruit.
I don't think there's any question about that it would, Henry. I visited with a plastic surgeon friend the other day who practices in Nashville, and she was in despair with the harassment that she has to go through with trying to her daily work, you know. And when I tell you that that Americans spend 20 hours per week per doctor in billing, and that it's 13% of revenues compared to Dr. Sheriff in Canada, 1%. His whole division overhead is 1%. I thought his description was really a very illuminating account of what it's like to practice medicine in Canada, where you take the business profit taking out, and so I think it would hopefully there are more physicians are taking their own lives, 400 a year. They're despairing. They're quitting. They're quitting young when they should be helping people because they're still smart enough and they could do it. Yeah. Well, the overall design is a trust fund in Washington, and probably would be the Medicare fund. You would just change the name, and it would be an improved and expanded Medicare, and then regional offices, and then state offices under those. So that would be the design. Now, you've hit on an interesting point. So when I tell you that we're spending $8,000 per capita, and that's twice what other developed countries are paying, and they already are providing health care for everyone. So that's huge waste. So why don't we take some of this when we have single payer and apply it to improving the social status, the economic status of the population in some ways, because we know how important social determinants are in disease process. So rather than just having the wealthiest, still having the wealthiest healthcare system, why don't we do more than just do the standard comprehensive medical services? Now, when I listed the standard comprehensive medical services, but some of our group have recently questioned that we shouldn't take some of that and apply it toward improving social situations, which play such a strong role, a very important role in overall health. Yeah. Yeah. Well, there's a strong
of where to invest the dollars in healthcare.
So strong emphasis in this program on primary care. And there's a book on your reading list called The Breaking Point, which is about the primary care crisis by John Guyman from Washington State. He was a former president of the American Academy of Family Practice, and he's written wonderful books, but this addresses the primary care crisis and how single payer will move in that direction.
Nancy?
Well, that's in your hands. That's in our hands. Campaign finance reform. You know, we've got to get the pigs out of the creek. There's no other way but to change. What will it take to do that? Well, certainly we need to rise up. You know, think about slavery. Learn a little bit about slavery. The slaves were property. Our ancestors owned them. They owned these people, and the pro-slavery group didn't want to let them go because that was their money. That was property. And I think there's an analogy there. And what will it take? We certainly have to have some campaign finance reform. We have to get some honest legislators. Billy Townsend was a congressman from Louisiana, and he kept Congress open until 3 o'clock in the morning to get Part D, the Medicare modernization and improvement, or whatever it is, in 2003, and it prohibits under I don't know if it's actually a felony, but there's a law against allowing Medicare to negotiate pharmaceutical prices such as the VA does. And what did he do when he finished that term? He signed a $2 million contract with Big Pharma. Now, what's going on here? You know, the person who wrote the ACA was Elizabeth. I can't think of her last name right at the moment, but anyhow, she was a former WellPoint employee. So we just got to get, all of this mess fixed. How do we do that? I don't know. I don't know what it'll take.
Last question.
I was fortunate enough to spend some time in the Mckesson position, also as panel member I echo a lot of what your gentleman said in his convocation. But one of the things I wanted to get your opinion on was the notion of private insurance. In the NHS, there's still a rather sizable market of private insurance. We actually took advantage of that on two occasions. So everyone had access to the NHS healthcare. My son had to see a specialist and wait to get a flu season almost 6 months. We were able to use our private health insurance to see something. So there is still some discrepancy or inequality in healthcare, I think, who are fortunate enough to have access to an employer to have supplemental private insurance. The other thing is that you talked about compensation in NHS particularly. A lot of the compensation for physicians was generated through private healthcare. They work in NHS.
Excuse me, are you speaking, when you say NHS, are you speaking of Canada or the United Kingdom?
Great Britain.
Okay.
They receive the base salary through the NHS. The majority of the people that I work with also practice in a private setting and would generate almost the exact amount of income in half amount of time working in the private sector. That's how their salaries were sort of equivalent to what you were speaking about. I don't know if that's the way it is in Canada or not.
No. And the Canadian system, as well as our 676, prevents duplicative services. So unless now there's one override on that in Quebec, if they can demonstrate that the wait is too long, then they can go to a private to do it. But that's the only exception. But you can't have duplicative services or it falls apart.
Well, I want to thank you for being here today. I want to leave you guys with a message that I too don't know what the best system is and how to make it happen. But I'll leave you with this concept that I've learned over my career, and I have white hair now, so I can say this. The worst things that happen in this country have been waiting for consensus. The best thing has been because somebody had the courage to move them forward. And Martin Luther King said, leaders don't search for consensus, they mold it. Thank you.